But I'd like to move on to looking at Ponatinib in the upfront setting. So the EPIC trial was presented at this year's ASH, and Ponatinib has been looked at in the recurrent setting, or in individuals who have failed to have adequate responses, and specifically indicated in most of our clinical practices for those with a T315I mutation. But I think the EPIC trial, which looked at imatinib versus Ponatinib in the frontline setting, would be interesting to discuss. I don't know, Elias, if you have any thoughts.
Ponatinib is a very potent BCR-ABL inhibitor with activity T15I. So the investigators went for a frontline trial called EPIC, comparing Ponatinib 45 milligram per day versus imatinib 400. Unfortunately, midway, due to the emergence of thrombotic events, they had to stop the trial prematurely. And then they released the data as of April 2014. Clearly, what we see from the trial, there's higher potency with Ponatinib with a really MMR achieved very early on, 3 months and 6 months and 9 months, which is superior to what we've seen so far in CML. Unfortunately, the study is stopped, and then patients who were on Ponatinib had to switch to other TKIs, imatinib or investigator choice, and we will not get any information further. Now, with the short follow-up, we did see vascular events, thrombotic events, lower rate than what we've seen with the PACE trial or the phase 2 trial, but still the follow-up is short. That tells us that there's some signal, maybe lower upfront, but one should keep in mind the vascular events with these TKIs, Ponatinib less with nilotinib, and that will bring me, when I use Ponatinib today, about how to optimize my patients, what dose to be given, what do I do. The drug from the in vitro experience is very potent, and you may not need 45 milligram per day. Although the label is 45 milligram per day, I rarely use 45. I go at 30 milligram start, and then dose de-escalate once a good response is achieved and maintain it. I will try to optimize my risk factors. No, nobody can say I cannot treat anybody with risk factors, because each one of us has some risk factors. But for example, I'll be careful watching for hypertension, medicate hypertension. Somebody with dyslipidemia will be very aggressive controlling the cholesterol with a statin. I do not need internal medicine for that. I can do it myself. But if needed, one can consult colleagues. I will give baby aspirin if there's no risk for increased risk of bleeding. Although I don't have the evidence, it's all hypothetical about how these cardiovascular events are taking place. Are these endothelial lesions happening? Some people said it could be a vasculitis or spasm. So we don't know. In a lack of evidence, if my patient doesn't have an increased risk of bleeding, I will give baby aspirin, I will optimize statin, and advise them on all the hygiene of life, like smoking. It does help everybody. It doesn't need just to be done for somebody on Ponatinib. In any TKI, I'll be very careful. With the emergence of these vascular events, any TKI, I'm very careful. I will try really to optimize these risk factors. Ponatinib, nilotinib as well have a signal, as we reported earlier during our discussion. We do see less with dasatinib and less with bosutinib and imatinib as well.
So I just want to underscore that point, that when you have a patient who is started on Ponatinib, you start at either 30 or 45, whatever dose you've decided. And when do you make the decision, how do you make the decision to decrease the dose to a lower dose for maintenance to try to minimize the cardiovascular toxicity?
In the chronic phase, usually we start at 30 milligram per day. Again, off-label, I don't have the proof 100%. I start at 30 milligram per day. Usually once CCYR is achieved, and if somebody with factors earlier at a major response, I drop to 15 and maintain them.
So it's CCYR.
Again, it is debatable.
I'd like to underscore that there's not an indication for this. The hope is that with more time, we will have better guidelines and recommendations for how to prescribe Ponatinib. But some of us will start at the label dose, which is 45 milligrams daily, and once there's CCYR or another surrogate indicator, but we can use CCYR, for example, then decrease the dose to 30, and then if responses continues to improve, go down to 15.
Any advanced stage disease blast phase, usually we'll go with 45 milligram up front in combination with chemotherapy, and then once I have a CCYR, MMR I reduce to 30 milligram, and then CMR 15, and maintain them at 15 milligram.
What's interesting to me about the development of all 5 drugs is that we're a little challenged at knowing what the optimal dose is for an individual patient. And we we were so excited about the great responses early on, and then with imatinib, and then the great responses with second generations when imatinib wasn't working, that an effort to really figure out what the best dose is for the majority of patients or how to optimally dose an individual patient, it's been hard to do. It's hard to manage. And I think we all sort of believe that, you know, the upper level of some of these doses are probably more than you need for a lot of the patients. But I think we have to take care to avoid underdosing people or not getting the right effects from it. And so it's a real challenge, even for those of us who see lots and lots of CML patients. That's something I keep in the back of my mind. We don't really know the optimal dose of any of the drugs, maybe except for imatinib, which 400 milligrams I think most people would put in there as the basic dosing. And I think we need to keep that in mind when we're taking care of our patients.
And if I can just follow up with something that Ellie said about the the Ponatinib versus imatinib study. I'm not so convinced that the rate of thrombotic events in that trial was really that much lower than what had been seen previously, because the follow-up, as you pointed out, was short. Median follow-up was, I think, 5 months, and the maximal follow-up was 18 months, and yet serious thrombotic events occurred in 7% of Ponatinib-treated patients and less than 1% of imatinib-treated patients. So 7%, you know, with less than a year of follow-up, I mean, I think from the phase 2 analysis, my recollection, I could be wrong, I think it was about 8%, so 8% at 12
the
months.
Year, and then
so I don't look at this 7% as being encouraging in that regard. I agree that it's a shame in as much as the efficacy looks very promising in that study. The high rates of not only major molecular response, but complete molecular response looks very encouraging. Unfortunately, it's until this can be effectively mitigated, I think it understandably has to, you know, it cannot be considered for frontline management.
Correct.
Certainly.
And you know, for the 7%, I mean, I don't know if the company had the data just to do like sequential testing, maybe angiogram or something, to get to learn about the physiopathology, why it's happening, and then we can get a better sense for the future when we design our future trials.